I want to introduce you to someone, if I can get this slide. Oh, there we go. So I want to introduce you to Betty. Betty is a 65-year-old woman. She has a history of heart attack. She's had a bypass surgery, and she has congestive heart failure and substance abuse. She doesn't see her primary care provider that much, and she was admitted last year through the emergency department for chest pain and fluid in the lungs. Because she has no primary care visits, she has very little visibility to the health system. And so, in many ways, Betty is lost in the shuffle. So at Duke, we have a program called Duke Connected Care. Duke Connected Care is an accountable care organization. The accountable care organizations were created under Obamacare to try to bring new innovative models to the way we deliver healthcare in the United States. So this accountable care organization at Duke takes care of 52,000 patients, and it belongs to a subset of those programs called the Medicare Shared Savings Program. And essentially what that means is it incentivizes us to keep healthcare costs down while maintaining or even improving healthcare quality for patients like Betty. Now the thing is, if we're going to do this, we need really significant analytic tools to be able to do this. So can we predict whether a patient like Betty will be hospitalized or the next time she'll be hospitalized? And in many ways, if we think about Betty, she doesn't see her doctor very often. Can we even find Betty in Duke Connected Care? So what we've done at Duke is build a time machine and basically use machine learning and artificial intelligence to do this. So our time machine helps us do this. We can go forward and predict whether a patient's going to be admitted to the hospital in 6 months. And so we know the probability of their hospitalization. And the way we've done this is we've trained our time machine with retrospective data. So these data include what we know about the patient right now. So what do we know about the patient right now at a place like Duke, which is like any typical academic health system? We have federal insurance data. She is part of the Medicare Shared Savings Program. So we actually have those insurance data. And what we do is we look at the past year worth of those insurance claims. And the reason I say it gives us global scope is that it actually allows us to see, for instance, if Betty went to a different hospital, like at UNC, or went to an emergency room in Wake County. So we can actually see those claims because we don't actually have that within our own electronic health record data. So we have our electronic health record data, and we look at the past 10 years of our electronic health record data, and we look at her demographics, her diagnoses, laboratories, et cetera, et cetera. And with all this information, we've built this time machine that allow us to find Betty. So now we know Betty's risk of hospitalization across 32 different causes of hospitalization. And we can do this for all 52,000 patients at Duke Connected Care. So we're predicting 32 diagnoses across 52,000 patients. That's about 1.7 million predictions, and we do this on a monthly basis. And now we can risk stratify our population of patients, and we can actually say, okay, now we have a care management team. These are people who spend a lot of time working with the patients to help them optimize their care. And because that's a precious resource, we need ways to prioritize how we apply that precious resource. So now we can say, okay, if Betty's above risk thresholds for any cause, and specifically for congestive heart failure, now our case management teams can go and set up a home visit with a pharmacy tech, provide financial assistance for her medications, provide social work for helping her with getting transportation to her clinic visits. So now we have a way to actually see someone like Betty. Deep learning, machine learning, has helped us find Betty. Now, this is a great story. And Vinod Khosla, who is one of the premier venture capitalists in Silicon Valley, has even asserted that 80% of healthcare can be automated. I was actually at the conference when he said this, and as one of the relatively few doctors sitting in the conference amongst a bunch of software engineers, I was taken aback a little bit. And he's also said that healthcare is like witchcraft and just based on tradition. Again, a little bit concerning for someone who spent so many years in healthcare. And I think about, okay, I went to med school for 4 years, did grad school for 5 years, residency for 5 years. So basically, years wasted on witchcraft are 14 times 0.8, which is about 11.2 of all my educational and training career. So, I mean, that's not really the downside of automation or technology, but there are downsides. Here's this cartoon. I mean, all of you have gone to your doctor, and I bet in the last couple of years, especially now that electronic health records are prevalent, you almost feel like the doctor's taking more care of the computer than you. That's a problem. So technology has great promise, yet it is actually interposing an interface between the doctor and the patient. And this has real costs per se. This is a recent article in the Journal of the American Medical Association, actually published by one of my colleagues at Duke, Kevin Shulman. And what he did was he looked at all the activities that doctors and nurses and other clinicians spend on billing and documentation. And what he found was that a typical primary care provider spends around $99,000 of his or her activity yearly on just billing stuff. So technology has given us some bad things as well. It's created this monstrosity that we have to serve, and that's why the doctor's spending all that time typing in things on that screen. So the other component of this is that artificial intelligence and algorithms don't even inherently have ethics. And why is this important? So we've done great things to create sort of an air traffic control to identify a patient like Betty, yet ProPublica has shown that algorithms can have significant biases. You should go and read this series on the internet. For algorithms used to predict criminal recidivism, there are tons of bias embedded in those algorithms. For instance, ProPublica noted these two cases. You have a white gentleman, an African-American woman. This guy is pegged at having a risk higher, being worse, risk of 3. The woman having a risk of 8. And when you actually look at what happened, there was clear ethnic bias in the way these algorithms worked. So we have to pay attention. Even though technology can bring us great things, technology has significant perils, and we need to be careful about those kinds of things. Because when you are training a machine, it is machine learning. When you're teaching that machine, you're teaching it maybe even your own implicit biases that you're unaware of. So we need to pay attention to those issues. And we have to think hard about transparency and interpretability in algorithms. Here's a picture of how Google, all of us hear about how Google's great at recognizing cats on YouTube. So this is actually how Google does it. So this is a deep convolutional neural net, and that's how it learns. And when you look at that, okay, you can see those pictures, and you can see the faces, the cars, the elephants, chairs, whatever. And then the machine learning decomposes those into these little elements and uses those elements to make a prediction. This is very abstruse. We don't actually know how neural nets think. We know how to tell them what to base the rules on in which to learn something, but we actually don't ultimately know how they're doing that. And that leads to problems. So everyone, what is that picture that I'm showing right now? Right, it's a cat. Well, some researchers have manipulated that cat image, probably at a pixel level, and made it do this. In that Google has a famous machine learning model called Inception version 3. Inception version 3 is one of those things that recognizes the YouTube cats. Well, if you manipulate that image just enough, you tweak it just enough, you can convince Inception version 3 that that tabby cat is guacamole. So Inception version 3, you look at that bar, has 98% certainty that that cat is guacamole. So when you think about this application in healthcare, yeah, we found Betty. But on the other hand, we need to be very conscious of the fact that a 2-year-old can identify a tabby cat. And a 2-year-old will never mistake a tabby cat for guacamole. Maybe my son would, but what we don't realize is because machine learning can be so abstruse, when it falls off the rails, even if it works with great accuracy, in those few percent where it falls off the rails in ways that are completely uncanny to us. So we have to be very careful about how we use machine learning. Machine learning always has to happen in the space of human experience, human workflow. We've trained these models. We also decide how we want to use these models. We need to be very careful about that. Because code, it's fun to code. I trained as a surgeon. I now spend more time coding. But coding is just a tool, just like the scalpel. And like any tool that we've ever created in the history of human civilization, we can use that tool for good things, and we can use that tool for bad things. I can use that scalpel to heal a patient. I could equally use that scalpel to harm a patient. So we need to pay attention. Technology has great promise, and machine learning and data science provide incredible tools to how we might take care of people, but we have to pay attention. And I think one of the ways we do this again, I'm showing you our deep care management platform, is that it takes a village. These are all the different types of people that we use to build this algorithm. And all these different people represent different viewpoints, different subject matter expertise, so that we can always lock this machine learning algorithm in the context of delivering care from humans to other humans. I think it's very important that we pay attention to that. Because healthcare in the United States, I know we talk a lot about global health, right now healthcare in the United States is going the wrong way. Obama talked about trying to bend the cost curve. We've somehow succeeded in bending the cost curve the wrong way. What you see in that chart is United States lifespan is actually going down. It's gone down for 2 years consecutively. Yet the healthcare costs have gone up. So we're doing everything the wrong way, and certainly, no doubt about it, I'm convinced that tools like we've developed for deep care management, using predictions to help us take care of populations of patients, are going to help us bend that curve up. But we also have to pay attention to how we use this technology. And I never thought that I'd be quoting a CEO of a company that sends boxes of clothes to people in healthcare, but I actually think this editorial by Katrina Lake, who's the CEO of Stitch Fix, is really on point in terms of thinking of how we use algorithms and data science to take care of people. It's simple. A good person plus a good algorithm is far superior to the best person or the best algorithm alone. These have to come together. We all need to acknowledge that we're fallible, that the stylist, in her case, I'll say the physician or the nurse or the physical therapist, and the data scientist, me, we have to acknowledge that, and we also have to acknowledge that our algorithms are fallible. So I'd like to thank you, and hopefully you haven't put you to sleep with data science.